our distinguished guest speaker, Dr. Philip Payne from the Ohio State University. Dr. Payne received his PhD in biomedical informatics at Columbia University. Right after that, in 8 years, he has successfully established himself as an internationally recognized leader in the field of clinical research informatics. And he chairs the Department of Biomedical Informatics at The Ohio State University. Funded by multiple NIH grants, he has co-authored more than 140 publications in the field of biomedical informatics, clinical research, and translational sciences. He's also a fellow at the American College of Medical Informatics and holds appointment on numerous national steering and advisory committees through the American Medical Informatics Association, Association for Computing Machinery, National Cancer Institute, National Library of Medicine, and the Clinical and Translational Sciences Consortium, just to name a few. So today, he come to Charlotte to share with us his vision for the entire field of biomedical informatics for the next 10 years. So ladies and gentlemen, let's please join me to welcome Dr. Philip Payne.
So that was a really kind introduction that probably will be better than my actual talk. So I appreciate that. It's a little embarrassing. So as I said sort of earlier to a couple people, I always like giving this talk because this is one of the few talks where I get to sort of read the tea leaves and tell people a little bit about where I think the field is going. I guess by way of truth in lending, while I say this is a vision for the next decade, that's probably a little bit aggressive. It's probably a little bit more than a decade's worth of work when we sort of get into the details of it. But nonetheless, it makes for a compelling title, if nothing else. So just to sort of give you a roadmap of what I want to talk about today, I'm going to start by just addressing briefly 4 areas that I think everyone in this room and sort of at the other remote sites are probably familiar with, which are some driving factors that are shaping the environment that we're in today, including healthcare transformation, sort of what's going on in the delivery side of the health and life sciences world, the emerging and sort of rapid focus on big data, a corresponding emergence of sort of increased focus on systems thinking, and finally, the sort of overarching impact of translational science. And I think you're probably familiar with these terms, but I'll define them as I go in case you're not. And then I'm going to talk about a couple different areas of biomedical informatics that I think are very responsive to these emerging trends. And I won't sort of belabor them here, and we'll get into some details, and I'll give a few examples. And these are the areas that I really think as a community we have an opportunity to focus on moving forward to advance the state of knowledge and practice in our field. And then finally, I'll just leave you with sort of a couple thoughts about both how there's both a need and perhaps a directionality around actually defining a central dogma for biomedical informatics, which arguably has been missing for some time, but I think is rather simple when you get down to sort of the reality of it, and also how this all fits into the evolution of what I would call sort of the modern academic enterprise. How does this work in an environment such as where we are today at a university? I guess I should begin by saying you shouldn't trust a thing that I say to you. So truth in lending have lots of conflicts of interest and disclosure on here, including funding sources, corporate sort of consulting and other roles. But I will do my best to steer clear of any conflict. But again, I'm always sort of a transparent person, so there you have it. So let's begin by talking about this changing biomedical and health sciences landscape. Now I won't have anywhere to sit if I get tired during the talk. So let's start by talking about healthcare transformation. Many of you sort of intersect with healthcare delivery organizations or are sort of students of the field, but just to sort of reiterate a couple of high points, you could say sort of writ large that healthcare is undergoing what is the most significant evolution in the delivery of healthcare services since the launch of Medicare in 1965. So why is that happening? First of all, we have what I think many people would agree is an unsustainable healthcare system. We're currently spending about 18% of our GDP in the US on healthcare, and that continues to rise and frankly is unsustainable. We have many different sort of policy agendas that are attempting to address this sort of financial crisis, sort of moving or bending that cost curve, including the Affordable Care Act and others. But nonetheless, even with all these policy agendas, as we look at sort of the landscape, we're spending huge amounts on administrative overhead. We have a huge amount of waste in terms of repeated tests and clinical services that are delivered but are not necessarily well indicated. And you could probably say at a very conservative level that there's at least 750 billion with a B, in avoidable costs in the healthcare system out of $2.8 trillion right now that could be trimmed with more data-driven or sort of empirical approaches to healthcare delivery. Which leads to the second factor that's making healthcare transformation a topic of discussion, which is that we are beginning as a field to recognize that data is changing fundamentally how we deliver healthcare. We're starting to look at how we use personal health records, ubiquitous sensor technologies. How many people in this room have a Fitbit or a technology like that, right? Tracking everything we do, how much we sleep, how much we walk. There's any number of sensor technologies. We're starting to look at predictive modeling for decision making, right? How do we identify patients at risk of readmission and intervene early so that we don't get penalized if they come back to the hospital within 30 days of discharge? There are initiatives at the government level to make health data open and accessible like other data sets so we can start digging into claims data, utilization data, and the like, and understand better at a systems level nationally how we're spending our healthcare dollars. So what are the impacts of these healthcare reform mechanisms? Well, as a lot of people would say, a healthy margin can hide a lot of sins, right? So for a long time in healthcare, we were making a lot of money, and therefore we could accept a lot of the problems that we had in the system because that large margin, that healthy margin, covered it up. But as the margin is starting to get smaller and smaller in the healthcare field, we're starting to see more of those fundamental gaps that healthy margin covered up, right? So these long-standing advantages that specialized care delivery or integrated delivery networks had, the competitive landscape between various health systems, the balance of power between physician executives, insurers, employers, and the like, is all changing. And we're seeing lots of new players emerge in the healthcare market. For example, we're seeing lots of care management firms that work on behalf of employers who pay for health insurance to manage the care of their beneficiaries outside of the normal healthcare system to try to prevent them from interacting with healthcare providers in the first place, right? That lowers costs for employers, but it also whittles away at that margin in the healthcare delivery side. So the fundamental problem that we have, if you take this all as a whole, is that the business model that we've been operating under in the healthcare world is a bad business model. The incentives are misaligned with what we want to achieve and who is paying for this, right? How many other fields do we have where the person receiving the service and the person delivering the service have no idea what it costs, and there's actually a third person paying for it at the bequest of a fourth person, the employer of those individuals in most cases, right? The obfuscation around cost and incentives is massive. So this leads to a fundamental question: what data do we need, even with some of the emerging data-driven decision-making, to help drive reform to address this bad business model? And if we could sort of imagine this world where measurement of all the things that we're doing in healthcare becomes more commonplace, would we then be able to learn from every patient encounter so that we could improve that patient's care, the care of their family, the care of their community? Could we actually unleash the power of observation, make smart decisions, right? If we look at the retail sector, and I talked about this earlier today, a company like Amazon.com has gotten to the point where they can pre-position products on a UPS truck by predicting what you're going to buy so that you can get that product delivered on the same day. Why can't we do the same thing in the healthcare world? We certainly have that much data. We simply don't marshal that data to make smart data-driven decisions like that. And this will ultimately require us to tightly link research and practice, right? We can no longer look at this straw man demarcation between what is research and what is clinical care delivery if we're going to achieve this sort of goal. So this has also sort of brought about a renewed focus on big data. I think this is a topic you probably heard discussed, but at the core of many of these opportunities is this issue of how do we actually leverage all this data in light of the fact that it's very significant in its volume, it comes at us very quickly, and it's highly variable. And while lots of people talk about these three V's, I would say in healthcare and frankly any field, really big data is about any data set where our conventional approaches, and certainly the conventional approaches we use in healthcare and life sciences, are not sufficient to generate actionable insights, right? Knowledge that we can take away from that data to solve a practical problem. Why do we have this explosion of big data in biomedicine? Well, it's not new. It's perhaps an area that we've refocused upon. But fundamentally, we generate massive quantities of data in almost every aspect of what we do in the health and life sciences. We have enterprise systems and data repositories like electronic health record systems, clinical research management systems, and data warehouses. And then we have any number of emergent sources like personal health records, instrumentation, molecular phenotyping, environmental data, ubiquitous computing technologies like sensors. If anything, we are drowning in a sea of data. And I don't want to overemphasize that point too many times, but this is one of our fundamental problems. We're really good at collecting data, although there are some flaws there, but nonetheless, we can certainly generate it in large amounts. We're really good at being focused on how do we store and secure all that data. That's a big focus for us in healthcare. We are not good at thinking about what do we do with that data. How do we make it liquid, and how do we generate actionable knowledge from it? Simultaneously to sort of this emerging healthcare sort of transformation agenda and the sort of concomitant growth in big data, is a sort of growing sense in the scientific and research community that systems thinking is a path forward for solving complex problems. And I think we see this in lots of places. I put up here a definition from the most scientific of sources for what is system thinking, Wikipedia, right? When in doubt, go to Wikipedia, although I think it's a pretty good definition. But at its core, systems thinking is about not dealing with a problem in its sort of individual or subunits and missing the interaction at a higher level, but rather dealing with the hard sort of truth of reasoning at that systems level and finding those interactions that are otherwise lost if we break down complex problems into simpler subunits. This is really a function of an evolution, and I could give an entire lecture on this, but I will resist the temptation, from reductionism to systems thinking, right? So our entire scientific enterprise as we currently know it is based on reductionism, right? Reductionism that came apart because of limitations at sort of the dawn of the modern scientific era of instruments that we had, like the human eye or the light microscope, and the inherent limitations of human cognitive capacity that caused us to believe that the only way to solve these problems was to break down complex problems in these subunits, sort of understand them, and then reassemble that knowledge, and then ideally get a grasp of what the big system is about. And this influences everything from policy to education to research and practice. Departments in a university or in a medical school or a hospital are a function of reductionism, right? Patients that show up and have endocrine disease and see an endocrinologist don't only have endocrine disease, right? They often have heart disease, or they could have cancer, or they could have an inflammatory disease that requires a rheumatologist. Yet we treat each one of those like they're distinct silos when in fact they're all interacting together. That's an example of reductionism in practice in clinical care. However, recent scientific paradigms that we see emerging have shown us that reductionism doesn't always allow us to arrive at the ground truth of these complex problems, and that's where systems thinking comes in. We see those benefits already in areas such as systems in biology and medicine, where the derivation of complex network-level analyses of biological systems have allowed us to identify critical genes or gene products, for example, that are targets for therapeutic or diagnostic interventions around a disease. Targets that, because they're highly interconnected with other components of that broader system, are very important and may have been missed if we had broken down the system into its constituent components. And if you're really interested in this, I highly recommend, there's a great set of papers by Lee Hood and colleagues that sort of enumerate this argument for a graph or systems level approach to diagnostic and therapeutic discovery. So this reductionist approach that's prevalent also exists in health IT, informatics, and other areas. So clearly this is an emerging way of thinking, but it tightly interdigitates with the problems that we see around making sense of big data and attacking these big complex problems that we see in healthcare delivery. Finally, as I mentioned, and perhaps as a bridging sort of dimension, is translational science. Lots of people talk about translational science, about being from the bench to the bedside. I'm an informatician, so I like to say it's from the lab to the laptop, right? So nonetheless, the idea here is that we want to more tightly connect these areas of basic science, clinical research, and clinical and public health practice so that the knowledge generation that we engage in from a research standpoint is continuously and in a cyclical manner brought forth and applied to solve clinical or population health level problems. And there are common information needs or informatics needs across all these various components, but this is an example of reductionism versus systems thinking, right? In a reductionist world, we would treat basic science, clinical research, and clinical care as sort of distinct activities, and there might be the occasional unidirectional transfer of knowledge from one point to another. That's how we've gotten the 17 to 20-year life cycle that it takes to get a discovery out of the lab and into common clinical practice. In a translational science paradigm, we sort of flip that on its head and say all of these things are connected in continuous cycles and there's feedback loops throughout. And if we're constantly feeding data, information, and knowledge amongst basic scientists, clinical researchers, and practitioners, we're able to break down those barriers and get this sort of research into practice more quickly, which I think we can all agree is a desirable endpoint. Again, if you're a fan of sort of nomenclature, there's sort of a common verbiage where we talk about these blockages, which are technical and cultural and social at sort of the T1 juncture between basic science and clinical research, and again at the T2 juncture between clinical research and clinical and public health practice. This drive for translational science, in my sort of estimation, has been driven by two major factors. One, as I already alluded to, that extending timeline associated with new therapy and diagnostic discovery, right? I don't think anyone is satisfied with this 17 to 20-year timeline. And then simultaneously, that data tsunami that I already alluded to that is facing the health and life sciences as the advent of data collection and generation tools outpaces our ability to make sense of that data. So, admittedly, I've painted a somewhat bleak picture, right? I basically said that our healthcare system is extremely challenged. It's not economically viable. There's a lot of forces that are making us fundamentally look at our business model. At the same time, we are drowning in larger and larger amounts of data and not using that data to make intelligent decisions about how to reform the healthcare system. I've talked about how, in part, this prevalence of reductionist thinking rather than systems thinking has been a major blocker to addressing this big data challenge that may lead to insights that allow us to address fundamental issues in the health and life sciences. And then finally, I've talked a little bit about translational science as sort of a hopeful horizon that we could move towards that might address a number of these areas. So that's a little bit of a bleak picture, but I actually think it's quite a bit more positive than what I just painted. It's just that it'll make for a more dramatic counterpoint now that I sort of move into sort of this forward-looking part of the talk. And what I want to talk to you about now is some of the responsive trends in biomedical informatics as a scientific field that will help us to overcome some of these barriers and address some of these really, really important areas of research, development, and practice, and that I think will form a roadmap for the next decade or more of innovation in our field. So to sort of set the stage for that, I do think it's important to think about where we've come from in informatics as a scientific discipline over the last 60 years. First and foremost, as a scientific arena, biomedical informatics suffers from both the benefit and friction of being both a basic and applied science. That makes it hard for some people outside our field to understand what are the services that we might provide in an operational context versus what do we do as scientists. And so that's very challenging. But we do engage in basic science, the derivation of new theories and methods that correspond to things like standards and data representation, knowledge engineering, cognitive and decision science, human factors, computational biology-related algorithms and theories. We also, as I said, engage in applied science. This is where these theories and methods get sort of put into motion to solve real problems. Things like electronic health records, clinical decision support systems, as well as biomolecular data analysis pipelines. Just in the EHR context, I have often given this talk, there is this belief system in many healthcare delivery systems that there's this great divide between IT and informatics. And one of the things I like to do is put up the history of one of the most common electronic health record systems that we see, including the one we use at Ohio State, Epic. Right? Epic is the result of research that occurred in the 1970s in academic laboratories in what would now be described as informatics programs at the University of Wisconsin. Right? Electronic health records didn't fall out of the sky fully formed and ready for people to use. Right? They are the result of rigorous research and development over decades and decades of work. We're now working on the next generation of tools like that when we look at genomics, clinical decision support, and the like. And there is this intersection between basic and applied science that defines our field, and that's where the boundaries are quite fuzzy. I think it's interesting, actually, if you look at the diagram on the right side, at least my right side of this slide, which is we've also seen an evolution in nomenclature that I think is indicative of the broader and broader scope of the field of informatics. Because if you go back in the 1950s and 60s, you might have seen the field referred to as AI in medicine. Over time, it's been referred to as computers in medicine, medical informatics, and now more commonly biomedical or health informatics, as you describe it here. And it continues to be a debate in terms of nomenclature. In fact, I always tell people, sort of somewhat tongue-in-cheek, it wouldn't be an informatics meeting if we didn't have at least one lengthy debate about the definition and name of our field, because that's what we like to do as a pastime. So given that sort of a roadmap of where we're coming from, where do I think we're going for these next 10 years relative to those responsive trends? Well, I think that translational bioinformatics, taking bioinformatics and computational biology approaches and linking them more tightly with the clinical arena is going to be a critical driver of innovation. This is tightly related to what I describe as in silico hypothesis discovery, right? Making more sense out of these large data sets that we have in a high throughput manner. There's also an emerging trend around what we call evidence-generating medicine, such that evidence-based medicine becomes less of a unidirectional flow and more of a cycle. I believe that there's opportunities in cognitive and predictive analytics. I think there is a renaissance in workflow and human factors. I talked about with some of the trainees here today. Why is it that clinicians hate electronic health records? Well, they hate them largely because they're poorly designed, right? So the user experience the electronic sort of health record provides is largely a function of sort of historical precedents, not a deliberate approach to understanding the human-computer interaction dimensions of such tools. And then finally, implementation science, actually studying the impact of technology in the clinical arena and understanding how that can feed back to the science we do as informaticians, as well as workforce development. We're going to have to get smarter about training a broad workforce of people that can work in this space. And at its core, this vision is about moving from sort of making sense of all the high throughput data we have to delivering knowledge-based healthcare based on that understanding, to looking at informatics as an intervention in and of itself, where we as informaticians ask and answer questions, and then finally training the future health and biomedical informatics workforce so that they can use these tools in new and impactful ways. So first of all, I talked a bit about this biological data tsunami. And I alluded to the sort of promise of what we call translational bioinformatics. And this is the idea of sort of bridging the gap, if you would, between the traditional methods that we think of as being bioinformatics or computational biology oriented and those that we think of as being health informatics or clinically relevant. And that's where translational bioinformatics comes in, at that T1 juncture. This is about delivering tools such as network-level analyses that link biomolecular phenotype with clinical phenotype, so we can start asking questions about how genomic profiles that we might identify at the bench can impact clinical decision-making in terms of delivering adaptive therapies, right? Can we predict outcome to treatment based upon an understanding of a patient's unique genotype? That will only be possible if we analyze that genomic data in context with our clinical data. And that means clinical researchers, bioinformaticians, and basic scientists are going to have to work as teams to bridge those gaps, as opposed to sort of developing that knowledge in vertical silos. And there are many methodologic areas that will contribute to this, right? We hear people refer to them as clinical genomics or genomic medicine or pharmacogenomics or genetic epidemiology. These are all just sort of glimpses of the nomenclature. But the point is, people working at this intersection point between those tools and health informatics will provide us with the basis for bridging that T1 gap and accelerating this type of work. At its core, if you were to ask me, and I'm a person that works in this space as part of my laboratory, this is about applying network theory as well as the basic science and clinical science that we understand about various disease states and bridging sort of these various multiscalar models of health and wellness in a meaningful way so that we can generate and test hypotheses. Here's an example of a tool, and I'm going to shamelessly plug a few tools from Ohio State because, to be honest with you, that's where I work, so why not? Although I do have to say I did like in the introduction that you used "the" multiple times in the introduction, which is the appropriate way to describe the university, which people often mock us for. But nonetheless, translational bioinformatics, what does it look like in action? This is an example of a tool that's been developed by a postdoc and a clinician investigator in our department who work in the oncology domain called MatchTX, and it's actually a tool that it satisfies sort of at a genomic level sort of this patients like mine question. I have a patient in the clinic in front of me. I actually know their genotype. I've been able to get sequencing data, whether it be microarray, exome, or whole genome sequencing. I've been able to match them against other patients for whom I have such sequencing data, look at their clinical data, visualize the similarity of this patient to those other patients, and show the probability of success of various treatment paradigms for their cancer in a sort of highly interpretable manner, right? So this is an integrated platform that links biomolecular and clinical phenotype in real time for clinical decision support to help in treatment planning for multiple cancers. So this is an example at sort of the applications level of how we connect the dots in that sort of translational bioinformatics paradigm. The second big area that I alluded to is in silico hypothesis generation, right? So we assemble large amounts of data on a regular basis, but we're really not good about asking questions in a similarly high throughput manner. In fact, the state of the art in sort of hypothesis formulation is largely the intuition of the individual investigator. Now, there's nothing wrong with that. It's just that there's only so many investigators relative to the proportion or scale of these data sets. So the question is, can we take all these disparate data sets? Can we mine the domain literature, ontologies, public data sets, and the like, and build knowledge collections that can be applied using, frankly, off-the-shelf artificial intelligence techniques in order to identify potentially interesting interrelationships between data elements that make up these large, expensive data sets, and then deliver those to investigators so that they can prioritize, interact with them, and test them, and see, are these viable or useful hypotheses? So what does that look like in action? So this is an example from my own laboratory in a project using a method called constructive induction, something that's been sort of rediscovered from the computer science literature from a number of years ago and applied in the context of biomolecular data, in which we've been able to take these graph-like contexts, and I'll explain in a minute what we're looking at, and these are derived from the metadata that describes a patient data set for chronic lymphocytic leukemia, in which we have 6,000 patients worth of data for over a decade. We have biomolecular phenotype, patient-reported outcomes, and clinical data. We've been able to map that data to a set of common ontologies and literature-derived extracts, then look at what are the potentially interesting interrelationships that exist between biomolecular and clinical phenotype markers, and prioritize them and visualize them. And what do we see? Well, I want to draw your attention actually up here to the upper right corner, which is a semantic network that correlates commonly known chromosomal loss that actually correlates in the disease that we're looking at with the aggressiveness of the disease and its tissues of origin, with a number of interesting laboratory findings, including white blood cell doubling time, something that we commonly use to look at the aggressiveness of disease from a clinical standpoint, and a set of proteins that are expressed in other analogous cancers, in this case in myelogenous cancers, and had been codified in the literature. We were able to find, using this hypothesis, something we had never tested before, which is that using histone expression profiling, we could come up with a signature to differentiate patients who may or may not respond to common frontline therapy with a degree of sensitivity and specificity in excess of 80%, which we had never seen in the disease before, and now are studying in a correlative study as part of an ongoing clinical trial with the NCI-funded CLL Research Consortium. This is a hypothesis that was generated entirely in silico, right? Not in the lab, not in the clinic, but by mining ontologies, mining the literature, mining public data sets, connecting that with the data set that this research consortium had created, and then finding something interesting that our investigators agreed they wanted to test and bringing that forward into clinical research. And this is the sort of opportunity where informaticians can actually ask and answer questions. As I mentioned as well, there's also this idea that if we could master this art of high throughput evidence generation, we could then get into a world in which evidence-generated medicine becomes the norm, right? This is where, instead of thinking as evidence-based medicine as a unidirectional concept in which we identify new knowledge in the lab, we hand it over to clinical investigators, they do their clinical studies, they publish their results, maybe somebody reads it, and then it gets applied in the clinic. Instead, we actually instrument the healthcare ecosystem. So we're constantly getting data from patients, providers, and their family members. We extract that information using common informatics methods, such as data modeling, knowledge management, and the like, that we deliver it to policymakers and educators and researchers in near real time so that they can understand the trends that are evolving that data, formulate hypotheses, perhaps using those in silico methods that I just alluded to before, then test them using various analytical methods at sort of a systems level, generate a knowledge base of actionable knowledge, bring it back to the point of care via decision support, and then using implementation science methods, study the impact of that decision support in real time. And in an idealized view, and I sort of would draw your attention to a set of papers recently published by the Academy Health EDM Forum and others, this could be a model that would bring down that discovery pipeline from a factor of 17 to 20 years to maybe a few years if we could do this, right? And there's ample evidence. There was a study done in Parkinson's disease by researchers at Google using a combination of methods much like what I've described here, as well as crowdsourcing, in which the results of a very reputable and complex randomized controlled clinical trial that took 8 years to complete were replicated in around 6 months. So that's what happens when you harness the power of all this data and start asking and answering these questions in high throughput and cyclical manners. Here's an example of a tool that is a sort of primary sort of case of evidence-generating medicine in action. I talked to some of you about this. This is a tool that we can deliver inside of the Epic EHR that visualizes cardiovascular health profiles for patients who are largely underdiagnosed, basically women over 65 in certain socio-demographic groups. And this is a collaboration between our department and the College of Public Health. And what we're able to do is take the American Heart Association's Simple 7 criteria, extract that data from the EHR, as well as patient-reported outcomes, calculate risk scores, deliver it in an easily interpretable visual form at the point of care, allow patients and providers to use it as a basis for conversation around lifestyle-related interventions, and then track those patients as well as the clinicians to see if their decision-making changes and bring that information back to further optimize this delivery tool, right? Completing that cycle. This is a tool that we built in 6 months. We delivered it. We're studying it. We're getting data every day out of this, and we're learning by that daily feed how to improve the delivery of evidence-based practice at the point of care for these patients who otherwise might have been underdiagnosed for cardiovascular disease. Another big area that I think is going to be tremendously impactful, and sometimes I describe this as a renaissance of clinical decision support, is sort of a cognitive systems analytic model to dealing with sort of complex clinical decision making. So in traditional clinical decision support, we often think about sort of a traditional unidirectional model in which we looked at targeted patient cohorts. We might do statistical analyses and the like, find evidence of sort of rules that should be applied at the clinical level, and then deliver those in various risk reports and alerts to clinicians. In a cognitive systems analytics model, we now think of this much like I talked about in evidence-generating medicine as being a cyclical process in which we look at the entire care population as well as the delivery ecosystem, not just the patients, but the providers, the environmental factors, socio-demographic factors, and the like. We actually do dynamic analysis and modeling using advanced machine learning methods in which it's not a single analysis, but analysis that's constantly shifting. Because guess what? As soon as we intervene, the characteristics of that environment changes, and so it's not a static target. And then we use contextual knowledge, like who are the care providers? Should this go to the patient? Should this go to a care provider? Should we visualize it? Is this an active or a passive alert? All the cognitive dimensions of how we best support decision making and tailor the delivery of these decision support alerts, whether it be through the electronic health record, mobile devices, personal health records, etc. You know, just to sort of amplify this point with the traditional model, we have a project right now at Ohio State, which is a collaboration with the Coriell Institute, in which we have over 2,000 patients that we have done targeted sequencing on that identifies certain risks they have from a pharmacogenomic standpoint. And we deliver that information back in our EPIC electronic health record, a state-of-the-art electronic health record for clinical decision making. How do you think we deliver those risk reports from the sequencing information back to the clinicians at the point of care? Does anyone want to venture a guess what it looks like? Nobody wants to venture a guess. You're laughing, so you must be thinking something.
I'm afraid to say paper, but...
It's almost as bad. Okay. We have a PDF. The PDF is about 30 to 40 pages long, and it is attached as an attachment to the patient's medical record. How many people think in the 5 to 10 minutes that the clinician's in the room that they are going to open up the 25-page PDF, review those genomic findings, and make a change in their clinical decision-making habits? Anyone think that's going to happen? No, it doesn't happen. They don't even open the PDF, right? Because they don't have time. That is not a tactic, right? Because it ignores the workflow, the human factors, the decision-making processes, and frankly, it's a static model, right? So this is the flaw in the way we're approaching the use of all this data from a decision analysis standpoint. This ideally, if we do it properly, will allow us to identify and use care trajectories to optimize not only clinical outcomes, but also cost, going back to what I talked about before. It turns out that paying more for care doesn't mean that you get better outcomes. In fact, oftentimes we pay more for care because we're delivering too much care that puts the patient at risk of more adverse outcomes. So identifying the right tailored therapy that's the minimum amount required to optimize the clinical outcome and reduce costs is a desirable endpoint. It's this idea of the triple aim, right? Reduce cost, increase quality and safety of sort of outcomes for patients. And being able to use predictive models in a way that's actionable, that clinicians can use at the point of care, that patients can be informed and be part of the decision-making process, and that we optimize for both of these dimensions simultaneously, that's sort of the holy grail of healthcare transformation. We are nowhere near being able to do that right now. It's why it represents such a wide open area, and I talked about that with some of the trainees today, of research and development for us, right? How do we make clinical decision support better? How do we model cost and outcome and include patient preferences and the like in the mix? And how do we make sense of the decision science that underlies sort of the optimal delivery of these sorts of tools and interventions? This ultimately allows us to go from predictive analytics as sort of an academic enterprise to sort of active decision support. And here we see sort of a diagram of what this enhanced sort of clinical decision support model would look like, which we not only have sort of findings and diagnoses that relate to patients, but also this conceptual knowledge about who should get the alerts, in what manner, in what capacity, guidelines and algorithms, really sort of blowing out the traditional model of just sort of the single-faceted knowledge base that we traditionally think of as being the basis for clinical decision support, and frankly, what is implemented in most of our commercial EHRs. Here's an example of such a tool that we built, in this case working with our sports medicine group, where we understood workflow and human factors at a level where we were dealing with trainers in the field consulting with student athletes who had knee injuries. And they were trying to make decisions about should they have physical therapy, should they have surgery, and if they have surgery, what kind of surgery should they have? So what did that look like? It's a patients like mine paradigm, again, where we look at the existing patients that we have. It dynamically calculates based upon the patient population we're looking at. It's delivered on mobile devices, so it can be brought into the field. It's actually delivered, in some cases, both to the patient's parents, if they're a minor, as well as to the provider in the field and the provider or surgeon back home. And it actually gives them the likelihood of both a success and failure rate, depending on the type of treatment that they select and what recovery time would be. Because student athletes, turns out, they care. If you're a fan of Ohio State football, you would know we care a lot about recovery times, especially for shoulder surgery. And unfortunately, a season is a long recovery time. So that actually leads us as well to some of these issues around workflow and human factors. I won't sort of belabor the point, but this is a critical dimension of all the things that I talked about. These are screenshots of a tool that we've built at OSU that allows for real-time time and motion studies at the point of care or in other environments in which we can capture this data, compare it, and visualize it and understand how people are using computers and other information artifacts. What are the sources of interruptions? How are they interacting? What are their communication pathways? And this is the sort of information that allows us to better understand how to target all of the things that I talked about before. That also leads to the implementation science dimension of what I've been describing, which is that we really need to understand how we connect these driving biological and clinical problems that we're encountering with knowledge workers, experts trying to solve real problems, so that we can actually identify what are the workflows that enable those people to engage with these technology interventions. How do we tightly couple engineering efforts and research paradigms so that we achieve an optimal outcome? How do we support interdisciplinary team science? And how do we make sure that human and cognitive science factors are interjected in all aspects of these projects so we don't end up with solutions that nobody will use? This actually leads to one of the important paradigms that I often talk with my trainees about, which is that while biomedical informatics and engineering are highly synergistic, they are not synonyms, right? They need to coexist alongside each other, and therefore we need to be careful that we assemble teams that bring both types of expertise to the table when we try to solve these problems. That does provide, and a lot of people ask me this, why would you worry about implementation science? It sounds very applied. I think it provides a tremendous opportunity to balance science and service so that we can actually solve real problems and engage in investigation simultaneously, right? We can look at informatics translation. What does it take to get knowledge out of our labs and into practice? You know, how do we model workflow? How do we understand those human factors? How do we do research on research, right? How do we understand which research paradigms work and which do not? While simultaneously engaging in innovative development and new theories and methods that make sort of these trains run on time so that we can represent knowledge and create semantic reasoning algorithms and engage in knowledge, sort of novel systems architectures to deliver these various computational interventions and the like. Then finally, I had said that I think that looking at workforce development is going to be incredibly important to us, right? So I think we have to align the way we look at workforce development, not as sort of a one-size-fits-all, which tends to be quite common in the informatics field, but rather as one that is tailored to individuals' roles and responsibilities. And at a high level, we need to think about who is it that needs to be acculturated to the field? Who needs to understand what informatics is and sort of how it applies to their decision-making at a high enough level that they know they should talk to informaticians before they make a decision, right? These are C-level executives, project managers, maybe clinicians and clinical staff. There's another level, at an increased level of acuity, which are people that need applied knowledge, right? They don't necessarily need to develop new theories and methods per se, but they do need to know how to apply those that have been empirically validated. These would be people like EHR-focused technical staff, software engineers, systems analysts, people that do technology deployment and support. And then finally, there are people, investigators, many of whom are in this room today, that we need to equip with foundational knowledge so that they understand how to develop and evaluate in a rigorous and systematic and scientifically defensible model new theories and methods, and also how to educate others as to sort of how to do this type of work. And right now, I don't know that we necessarily stratify our approaches to curricular design and delivery along these lines, and I think it's a tremendous sort of challenge for us as a field to mature and understand it really. We don't need to train every individual to be another informatics investigator. We need to train people at all these levels to fill out all of the gaps in the workforce. That really will require us to take a much more competency-based approach to curriculum design and career trajectory for people in informatics. This diagram sort of outlines a number of competencies and skills. that really need to come together and then be aligned appropriately in a tailored manner with various career trajectories. But the reality is different career trajectories require different mixes of these competencies. And I would argue, much like I talked about precision or personalized medicine as a way of tailoring therapies or diagnostics to an individual's phenotype and genotype, in a similar manner, we should be engaging in personalized education informatics. We should be looking at career trajectories. We should be understanding which competencies map and how do we tailor the curriculum that we deliver to trainees to match those career trajectories, rather than, again, using a one-size-fits-all model. At OSU, one of the things we've been doing is re-engineering our informatics curriculum as part of our master's and PhD level training to use a reverse classroom model, right? And I've talked with some of you that use that here, right? So we take all the traditional materials that would have been didactic and delivered through sort of lecture mechanisms, and we've made them online materials. And our trainees interact with them at their own pace and at the acuity level that they need. Some of them may need only one dose of a lecture. Some of them might have a hard time understanding the lecture and might watch it 2 or 3 times and do some additional laboratory exercises. And then when we bring the students into the classroom, we actually do experiential learning, hands-on laboratory or group exercises, field trips into the real world, working with our individual investigators. And we break our students into groups based upon their career trajectories. Some people are practitioners, some people are investigators, some people are medical students just trying to get familiar with the field, and we treat the experiential learning at different levels of acuity based on that. That's an example of where we can go with competency-based curriculum. And I will tell you that one of the things I've noticed is that at the end of the day, if you look at these competencies and what is required to demonstrate mastery, our students engaged in this reverse classroom model with more experiential learning are able to more quickly and at a higher degree of attainment demonstrate mastery of these competencies. So I think the proof is in sort of the data as to educational performance. I'd also point out that we have to be very careful when we think about training clinicians, because we often do not differentiate acculturation versus practice when it comes to informatics skills. So why do I have pictures of car-related parts up here? So on the left side, here's a picture of the inside of the car, and I'd say here's the steering wheel, the transmission, and the pedals, right? Who thinks if you've never driven a car, if I told you those 3 things and put you in the driver's seat of the car, you'd be ready to drive a car? Anyone think that that would be enough information to drive a car? I don't think it is. That's how we train clinicians to use EHRs. We put them in a room and we say, here are the buttons, here's how you log in, here's where you write your notes, go get them, right? When in fact, the healthcare system that we needs them to be in that lower right corner where they're able to use the EHR as a high-performing tool to improve quality of care. But we don't teach them like that. So that's an example where we haven't tailored the delivery of what is arguably informatics education, how to think about clinical workflow, documentation, the coding of data, the reuse of that data, right? If you go into the average clinician's office and watch them use an EHR and say, hey, you decided to write that in a note as opposed to use a structured data entry flow sheet. Why'd you do that? Do you think you're never going to use that data again? Do you want to query it? I would guess most of the clinicians have not thought about that. Even though in this rapid learning health system that we need to create, every clinician is going to need to be able to reuse their data to understand how they manage their populations, specifically if they're at risk for the health and wellness of those populations as opposed to getting paid for just performing procedures. So I'd argue this is, if nothing else, the most significant problem that we faced in educating an informatics workforce in terms of differentiating right now with the sort of explosion of health record adoption, this differentiation of acculturation practice. And the people in this room, the trainees that we're developing in programs like the one here, are the people that are going to need to figure out how to do that, right? That is a fundamental goal for our field that I think we all need to take on. So, finally, just to sort of round out the conversation, I think that a lot of the areas that I have alluded to fit into what appears to be an emerging central dogma for informatics. So if you don't sort of get the sort of metaphor here, there's a central dogma for molecular biology, right? You know, we have DNA, RNA, genes, gene products, etc., all interacting together. Okay, we don't have that really in informatics. Instead, we debate the meaning of the field. I would argue to achieve many of the things that I just spoke about, we need to think about informatics as a field that is focused on taking raw data and applying context to it so we understand the sources that data is used, generating information based upon that context, and then making that information actionable in the form of knowledge. That is what we do as a discipline. And this draws upon or is derivative on lots of different areas, such as information science, computer science, physics, mathematics, statistics, etc. But it's about this integrated problem that has to be addressed to bridge the gaps between data, information, and knowledge, right? Context and actionability. How does this fit into sort of the academic enterprises that's currently evolving? I think simultaneous to the evolution of healthcare, we also see tremendous change in the academic environment. Well, I think it causes us to think a bit about sort of where informatics fits versus the traditional model versus the emerging model. So where do we fit from a scholarly home standpoint? Many people say right now it's in a department or division, but perhaps because of the derivative and cross-cutting nature of what we do, it really should be in multidisciplinary centers and institutes that span institutions, rather than being sort of siloed in a given college or entity. From a revenue standpoint, how do we make this innovation happen? We have tended to focus on tuition and grant and service revenue, but perhaps we need to look at other mechanisms like technology transfer revenue, public-private partnerships, contracts, multi-center consortia, and the like, new sources of revenue. From a culture standpoint, we often argue that we have to be very disciplined about separating science and service. But using that implementation science argument that I brought forward, in fact, we should see service as science at the institutional and community level and embrace that. And from a dissemination standpoint, perhaps the traditional model of publications and presentations is not ideal. Maybe commercialization or translation of what we do into healthcare delivery organizations would in fact be a benchmark of dissemination as opposed to just writing another paper. Papers are important, but papers don't necessarily generate actionable outcomes for patients and populations. And how do we achieve the balance? I'm not saying that we need to make a wholesale shift from one column to the other, but I think we need to think more about where do we need to fit in between those columns over time. So what is my survival guide for biomedical informatics as a field moving forward? 5 key points. We have to fully embrace interdisciplinarity. Some institutions are better at this than others, but this applies to the structure and function of what we do academically, as well as looking at competency-based training. We have to pursue emerging or re-emerging research foci, not where we're at right now, but where we need to be 5 or 10 years from now. Our job is to innovate, right? This is in data science, which is an area that I think, along with big data and data analytics, is something that we need to embrace as a field, right? Because we have unique competencies in this area that can bridge many other complementary disciplines. Health services research and quality improvement, we need to embrace that as well. That's where the rubber meets the road in most healthcare delivery organizations. Decision science, human factors, integrating patients and communities into the research fabric, which we don't do very well at. Number 3, we have to engage with our health systems, right? Whether they be academic, regional, statewide, national. We need to look at how we provide analytic solutions, workflow and human factors understanding, and transformation advice to address these challenges. We need to develop better technology transfer and commercialization agendas so that we can de-risk technologies, get them out there, and generate revenue through new streams. And we need to adapt more strategies from the private sector, right? We need to find those unique areas that we can compete and behave more like startups, right? Where speed and agility, and so this idea that, as Steve Jobs would say, real artists ship, that we don't just satisfy ourselves with an intellectual thought experiment, but we generate an actionable sort of product that people can look at and use in the real world. These are things that we really need to embrace if we're going to adapt and survive in this new environment. Just a final word on training. People are very excited. Biomedical informatics and health informatics was referenced in a recent U.S. News and World Report as being sort of a central and hot career for people to go into. And everyone said, this is a sign we need more money for biomedical informatics training programs to create more investigators. It is not. Read the article. The article talks about training practitioners, right? That's where the growth area is. Not that training more investigators isn't important, but I think we shouldn't look at these sort of reports from outside our community and sort of recapitulate them to fit our own narrative about where we think money and research and scholarly focus should fall. Read the article, it's fascinating. So I'll stop there and just say I would be dishonest if I said all of the ideas that I just presented were my own. I'm very fortunate to have a great group of collaborators in my own lab and all the various funding sources that make a lot of the research that I'm engaged in possible. So I want to acknowledge all those individuals. And I'll just leave you with a few sort of quotes that I think are emblematic of what I tried to convey to you in this lecture. Also point out that my email address is here, and there's a link to an online version of these slides. So if you're interested in sort of going back over this rapid-fire overview of the field, you are welcome to do so. And I actually just updated these last night with the most recent version of the slides. So thank you very much. So questions?
Thank you very much. Let's start question.
Sure. We have 12 minutes before apparently they shut off and disappear forever.
Are there any questions from Duke side?
You got just wait and speak up.
Okay. Yeah, I had a question. That was a great talk, and you mentioned a lot of issues and some of the things that we have to take care of. But I was wondering if you can speak to some of the informatics infrastructure that we can leverage and use for addressing some of these issues that you brought up, like in a sense, like most of them are very data driven. So is there like a specific set of information technology that we can use to address these? The things that you talked about, such as the data-driven decision analysis, new ways of doing analytics as opposed to the conventional ways, data liquidity and systems thinking or systems approach, and many others. But what I was wondering is is there a set of information technology platforms or technology solutions that can be used to address these, since almost all of them have the big data component.
So, I would be sort of a little bit hesitant to say that there is a specific technology solution, but I think you hit on a key term that I think is critical, which is this idea of data liquidity. So right now, when we think about sort of technology infrastructure, as well as the governance that surrounds it relative to healthcare data, the approach tends to be sort of highly focused on minimizing risk, controlling access, and centralizing that data such that we have sort of absolute certainty over who uses it in what capacity, et cetera. I think that the technology platforms and the governance models that we need to implement are much more about how do we treat all of this data as a strategic asset and create liquidity around it, balancing risk with benefit, and empowering knowledge workers, right? So what I mean by that, we need repositories and structures that semantically normalize this data, that allow for secure access to it by a variety of stakeholders at various levels of granularity, and give them the tools to be able to interrogate and interact with that data in sort of a meaningful way. There's no single solution for that per se, but I think this idea of an overarching theme of moving away from sort of data silos and towards an emphasis on data liquidity and enabling knowledge workers and the sort of front-facing tools as well as repositories and data integration platforms that underlie that, that's where we need to go. I would tell you, and this is a controversial topic, that part of that is, what is sort of IT versus what is data science and what is informatics, and who owns those areas and who makes those decisions about the design and governance of those infrastructures. And I would argue that IT and sort of the data sciences and analytics area and informatics are not all the same thing, and there are certain tasks and activities and infrastructure design and operational decisions that need to be put in the hands of the data scientists and the informaticians so that we can maximize benefit, as opposed to focusing on sort of delivering on time and under budget, which sort of is a core mantra for sort of what is success in the IT view of the healthcare world. Other questions? I'm looking at all the remote people. I see all four groups simultaneously, so it's...
Yeah. Okay. How about Chapel Hill? Are there any questions?
No, none from us. Thank you.
East Carolina?
Yes, yeah, thank you for the great talk. I just have one question about, our program called Health Informatics and Information Management. So we do have a program in Health Information Management, which is traditionally medical record management. Of course, that all moving to the technology domain. So what will be your insights if that profession needs to move up to the next level? You don't necessarily want to know everything about informatics, but what will be the intersection between the information management as well as the health informatics?
So first of all, you get extra points for being the only site that actually has the name of your site behind you in the visual. So I have to tell you, I appreciate that. At least I know which of the four boxes to look at. I would tell you that in my idea sort of stratifying how we teach, I think that people in the health information management world sort of belong in that middle sort of bracket, sort of practitioners that don't necessarily need to get a deep knowledge of sort of theories and methods sort of per se, but need to know how to apply them in meaningful ways. So to be concrete about that, in our own institution at Ohio State, we have a health information management master's program as part of our School of Health and Rehabilitation Sciences, what used to be Allied Health. Our faculty in biomedical informatics teach 2 core lecture series in that program, which is basically clinical informatics as well as informatics as it pertains to sort of study design, implementation science, and evaluation, right? So our belief is that those individuals, while they're involved in sort of the practice of health information management from a medical record standpoint, need to understand the sources where all that data comes from and the challenges of integrating and harmonizing all that data, while simultaneously also understand when we're trying to improve the delivery of information, what are the methods we use to study sort of interventions so we can think more empirically about it. So that's an example of that middle layer of sort of that competency sort of diagram I tried to lay out.
All right, thanks.
Are there any questions from NC Central?
Let me try one question that was very rapid fire. Thank you very much. And after 20 years of looking at theory about knowledge engineering and what we need to do, it was really a thrill to see how much you're doing. I hope you can consider letting us test some of your tools. But that leads me to the question about, so what about patents on these tools? Because some of your interfaces, I'm very interested in human factors, making sure the data is good quality data, and that can make a difference. Does the university own your patents? What are y'all doing?
So as you saw on my disclosure slide, we actually have spun out a company. Hey, good news, we end in 5 minutes. The screen is warning me too. So we actually have spun out a company from OSU that's licensed some of these technologies. Our approach from an intellectual property standpoint has been that the university owns intellectual property. That's sort of the policy at OSU. It's jointly shared from sort of a revenue standpoint with the faculty and inventors. But when we license our technologies to for-profit entities, we always retain the right to share them freely with any of our academic or nonprofit collaborators. So that has been our model so far. So we think that we can monetize these products from a commercial standpoint while still keeping the ability to work with academic partners. So all the tools I showed you are things that we could share and collaborate with folks like yourself on under sort of that academic or sort of open source release model with no sort of licensing hooks attached, while simultaneously I would say to you that many of them are also things that we've commercialized and we are making money on by selling to for-profit entities simultaneously. That's sort of how we try to strike that balance. And I would tell you right now, even with about an 18-month sort of level of experience in our belt of using that approach, we're generating revenue on some of these tools from a licensing and royalty standpoint that approaches that of sort of a standard R01 from the NIH, right? So that is a really nice source of money that comes back to the department to support new innovation and research. So I think that, a lot of people tend to get nervous about commercialization. I see it as a necessity, and you just have to figure out how to strike that balancing point.
Thank you.
And we can follow up about the tools. I'm always looking for collaborators on tools, so we'll follow up on that.
Great. All right, if there's no more questions from those remote side, we'll open questions here at UNC-Charlotte.
Dan. Dan's been dying to ask a question. I can see it.
Yeah. On your network science
Yeah.
diagram for the CLL, how did you discover that network? Was there an optimality criterion used? And I didn't. You said that histone was what the
histone expression on the protein. Yeah.
What the cancer specialists focused upon. How did that emerge from?
Yeah. So it's interesting. Yeah, so I glossed over sort of a couple key things. So, basically using this methodology that we have, we generate hypotheses in the order, starting with, say, a data set that corresponds to maybe 110 data elements. We can generate tens of thousands of hypotheses rather quickly, right? So that's an untenable amount of hypotheses. So we actually use a combination of literature-based support metrics. So we look at sort of prior reports of sort of correlation in sort of titles and abstracts of published literature as to whether or not something has been reported before, as a way of sort of looking at the inverse of that is sort of likelihood that it's a new hypothesis. So we can prioritize in that dimension the hypotheses, while simultaneously we also have some mechanisms from sort of a graph theoretic standpoint to sort of control for concept granularity to say, okay, this is going to be overly general or too deep based on how we traverse the source ontologies to sort of narrow the search space to something that's going to be rational. So we use those two dimensions, and then we have a web-based tool where we deliver them to the investigators and we crowdsource it. And the investigators can browse through based on these priority scores from the literature-based support metric and sort of the topology of the graph system and say like, hey, these are interesting, and literally it uses sort of a shopping cart-like model, and they dump it into a shopping cart, and that's sort of their virtual notebook where they say, I want to explore this hypothesis in the data further. And then frankly, we let them vote with their feet. So the one around the protein sort of expression profile being a potential surrogate for response to therapy, that was because in a group of about 10 subject matter experts from the CLL Research Consortium, we had a preponderance of people picking that as a high priority hypothesis. And it happened to be one where we had, to be honest with you, serendipitously, the ability to bring that tissue, which is already in play, to our protein expression group at OSU. Actually, it was Mike Frias who did it, and sort of do the analyses sort of retrospectively first. So we have a paper, which I'm happy to share, that sort of outlines the whole methodology. And the tool is called the token pipeline, and it's sort of, it's the Translational Ontology Anchored Knowledge Discovery Engine, a tortured acronym. But I can certainly distribute the link for the paper, which sort of explains in much more detail. Yeah.
The way I understand it,
Right.
Now, however, currently the entire system, talk about system science, currently the entire system from higher education to research to clinical practice is a specialist driven.
Right.
Which by definition, they only see a piece, right? How do you see from an enterprise